All right, so good morning, everyone, and thank you to the organizers for letting me present here today. Yes, this is take two. Yes, thank you, everyone. I'm Sarah Woller. I work at the National Institutes of Neurological Disorders and Stroke, and today I'm going to be telling you about the Preclinical Screening Platform for Pain, which is a program within the NIH HEAL initiative. There we go. So the NIH HEAL initiative was formed a few years ago with the overall goal of creating scientific solutions to stem the opioid crisis. And this falls under two broad categories, one being finding solutions to improve the treatment and prevention of opioid misuse and addiction, and the second being to enhance pain management. The HEAL initiative encompasses 20 distinct programs led by 12 NIH institutes and centers. And so the goal of the PSPP, or the Preclinical Screening Platform for Pain, is to provide a platform to identify and profile non-opioid, non-addictive treatments for pain. And so within the PSPP, we operate a bit differently than your typical grant program. So where you would submit a proposal for review and the NIH would fund that proposal. We work by providing a screening resource. And so asset owners who have potential therapeutics for pain can submit their asset to our PSPP program, and we'll then do the profiling of the asset. And so rather than giving you money to conduct the studies, we're giving you data. So we work very collaboratively with all of our asset owners. We accept small molecules, biologics, devices, and natural products for evaluation. And we also accept assets from asset owners worldwide, from academic institutions, industry, and also government. And so under NINDS direction, the preclinical screening of the assets is performed by our contract facility, Psychogenics Inc. in Paramus, New Jersey, in a blinded and confidential manner. And as I mentioned before, there's no cost to the PSPP participants. And so we evaluate these assets in a tiered manner. Our tier 1 screening consists of starting with an in vitro screen. So we look at functional activity at opioid receptors and a number of other receptors that are potential targets of abuse, because our goal is to find novel non-opioid treatments for pain. If everything looks okay in the in vitro screens, we'll then move on to a pharmacokinetic study to really get an idea of the overall exposure levels of the compound. In tier 2, we start the in vivo profiling. So we start with a side effect profile using a modified Irwin functional observational battery and also an accelerating rotorod. And these will allow us to make sure there's nothing that's going to confound our later behavioral data when we move into the acute to subchronic and the chronic and persistent models. And so for these two assays right now, we're using the plantar incisional model. And then for the chronic persistent, we're using the L5, L6 spinal nerve ligation. If there are signs of efficacy in these tiers, we'll then move into tier 3, in which we assess in vivo abuse liability using either an intravenous self-administration or a condition place preference paradigm. And we'll also then go into more disease-specific models. So things like the MIA model of osteoarthritis. All of this work is customized based on the asset. And so we work very closely with the asset owners to ensure we're getting the appropriate evaluation of their asset. And so having just walked through this, I want to walk through just a little bit of data using a clinical standard to show you what this evaluation of an asset would look like. And so we would start with the in vitro screens. The in vitro screens for ketoprofen come back with activity at COX-1 and COX-2 as expected. We then have some PK data here as an example. In this study, we looked at 2 different doses of ketoprofen, either 3 or 6 milligrams per kilogram PO. We do all of our assessments in both male and female animals. So we're using Sprague-Dawley rats for our studies. And so these were dosed. We collect plasma over a number of time points. Again, the time points would be customized to the asset. Here we looked at 6 different times over 24 hours. We also collected brain at 1 hour and 24 hours to have an idea of what the exposure profile looks like. And then we calculate the PK parameters. After the PK study, we move into the accelerated rotorod. Here we're looking for the ability of the animal to stay on the rotorod for a period of 40 seconds. And so at baseline, all of our animals, both male and female, are at 40 seconds. When we then test at 3 time points following administration of ketoprofen at 1 of 4 doses. So here we looked at 1, 3, 6, and 10 mg per kg in darkening shades of red. We see that the ketoprofen administration is not affecting performance on the rotorod. We also did an ER1 functional observational battery. I'm not going to show that to you here today, but it is another step that we take to really ensure that there are no confounding factors that might influence the endpoints that we're looking at when we move into the next models. And so we also look at the plantar incisional model. And in this model, we look at 2 separate endpoints. We use guarding score, which is on this slide, which is a non-evoked endpoint. So you have the animal on a platform and you observe whether they're holding their paw elevated or if it's on the floor. And so the guarding is the pain behavior. And so what we're looking at is over, we have a pre-op baseline and then a post-op baseline, which is 24 hours following surgery. And that's when all of our assessments are done on what we're calling day 1. We then administered the ketoprofen and assessed animals at 1, 2, 4, 6, and 24 hours following administration. And so you can see while vehicle animals in the light gray still show elevated guarding scores, the ketoprofen treatment dose dependently decreased guarding score in both male and female animals. In the plantar incision model, we also look at paw withdrawal threshold. And so this is an evoked endpoint using von Frey filaments. We use a 50% up-down method described by Chaplin. Again, we're doing all of our assessments in both male and female animals. We have the baseline thresholds at 15 pre-op. After the surgery, the thresholds decrease quite low. And here you can see that while there was a very modest effect of ketoprofen, the animals really aren't crossing a 5-gram threshold, which is where we would start to consider an effective anti-allergenic treatment range. And so we're seeing a difference in the data depending on whether we're doing the non-evoked or the evoked endpoint. And so we're trying to get a full profile and picture of how a compound is performing. And so just to summarize a bit, I showed you just very briefly parts of the tier 1 and tier 2 screening. At this point, depending on the data, we really sit down with our asset owners and decide what the best next steps would be in moving into tier 3. Another key component of the program is to constantly look for additional ways to evaluate these compounds. So whether it's a new model, a new endpoint, or incorporating another existing endpoint and really doing a strong validation so that we know we're getting a good profile of the compound. That's part of our ongoing work as well. And so we are currently accepting assets for evaluation. For eligibility and participation inquiries, you can send either of us an email or find us at the meeting. You can also visit the websites. I will note that the second website, you have to take the www out of, or you won't get there. But yeah, I'll take any questions.